everyone from San Antonio. I'm Elia Segui, a breast medical oncologist and translational researcher from Barcelona, but now a research fellow at Dana-Farber Cancer Institute. And I'm here today with my dear friend, Benja, from Chile to discuss updates, challenges, and controversies on hormone receptor positive breast cancer. Hi, Benja.
Hi, Elia. Well, it's a real pleasure to be here. I'm Benjamin Balbum. I'm a medical oncologist, specialist in breast cancer as well, and I work in Chile in Hospital Pontificia Universidad Católica. And as you've said, have been enjoying what's been this almost 4 days of San Antonio regarding specifically breast cancer.
So we've seen a data that was super expected. We've seen data from the lidERA trial. That's the first novel endocrine treatment with a positive outcome on the adjuvant space since 20 years or 20 or 25 years ago. What are your first impressions?
Well, the lidERA trial was presented by Aditya Bardia a couple of days ago, and it's a very interesting trial. So what they did is they selected intermediate and high-risk patients with endocrine estrogen receptor positive early stage disease and randomized around 4,000 patients to either giredestrant with or without ovarian function suppression, depending on premenopausal status, or endocrine therapy or standard of care, aromatase inhibitors and tamoxifen. And the trial, what it showed, and it's very interesting, as you've said, because we hadn't seen results or positive results in this scenario with endocrine therapy before in the last 20 years, is that the use of giredestrant reduced the risk of recurrence or invasive recurrence in around 2.8% and distant recurrence in around 2.1% in just 3 years of follow-up. And it's, to put this into context, it's very similar to what we've seen with CDK4/6 inhibitors at this same time point.
So do you think that with the data you've seen, are you willing to approach this treatment for your patients, or what do you ask? What would be your, what would you like? What data are you expecting to be able to adopt this?
I think still CDK4/6 inhibitors are the standard of care. Abemaciclib showed overall survival results in the last couple of months. So probably it's still a bit too premature to say this is going to change practice. So probably we've got to wait a couple of more months or years to see if this difference translates into overall survival in the future.
And what about the safety profile? Because I think that we all breast medical oncologists were expecting a much better safety profile when compared to aromatase inhibitors. But what we saw was that the tornado plot actually was quite similar with similar rates of arthralgias. And that was, at least to me, a bit disappointing. I understand that, like maybe there's different kinds of, like arthralgias, and maybe we're not collecting this data properly. That might be one. But I think that, like having to use ovarian function suppressant for all patients, right? For all premenopausal patients can be one of the causes of this safety profile. What are your thoughts on that?
Yeah, well, I think there's two things. The first thing is actually, I feel the same way. It was kind of disappointing to see that there weren't big differences regarding toxicity. It is true that less patients discontinued therapy with giredestrant, but probably that's got to do with other things, such as the open label design of the study. And as you said before, there's some data today or yesterday, a premier trial was presented, and it showed that there was an equal response measured by Ki67 with the use of elacestrant, another SERD, in the neoadjuvant setting, with or without ovarian function suppression. So it comes to reinforce the possibility of avoiding the use of ovarian function suppression with this new oral SERDs, and that actually would mean a big change for patients, maybe translating into better tolerability.
So I think, in conclusion, we both think that oral SERDs are maybe better drugs, just like their design is better. But I think we both agree that the data is quite immature and we are not yet ready to implement it. And when we are, we will have to see what do we do with CDK4/6 inhibitors. Do we combine SERDs with CDK4/6 inhibitors? Do we keep the oral SERD for the patients that are not candidates for CDK4/6 inhibitors? And another question I have for you, if we use oral SERDs in the adjuvant setting, how do you envision the sequencing of oral solids in a metastatic setting? And I think we can move now, like, the discussion to the metastatic setting.
Yeah, well, just to close and maybe confirm what you said, and totally agree with what you just said, is that this new data just brings new questions as well. So it probably, for Monday, there's not going to be big changes regarding the adjuvant therapy in estrogen receptor positive disease, but it's very interesting to see what's going to happen in the next couple of months. And as you said, in the metastatic disease, we also saw a lot of changes in the last couple of months. We've seen, well, CDK4/6 inhibitors still remain as the standard of care therapy for first line, but we had data on the use of inavolisib for patients that recurred during adjuvant therapy, so they are resistant to endocrine therapy with PIK3CA mutations. What's your takeaway about this new data?
So I just, just to briefly summarize, this is a study that basically assessed, evaluate the efficacy of a triplet combination of palbo, inabo plus fulvestrant versus palbo and fulvestrant, so a triplet versus the standard doublet. And it's a trial that's positive for both PFS and I think what's more important for overall survival. So we do have to, we need to take this into account. I think there's the other trials studying, like inabo with a combination of SERDs, but I do think that a triplet combination, it's hard for most patients in terms of toxicity, but I think this high-risk population, at least we do, for some patients, I do think that we need to use this or try to use it because I think it's beneficial for some of them. I always have the question, right? Would it be better if we just sequence CDK4/6 inhibitors and then we use PIK3CA in a later line? But I think we don't have data to answer this question. How do you think? Are you more leaning toward a triplet combination or a sequence approach?
Yeah, well, I agree. Well, it depends. Probably, if you think about all these trials, at least for me, and I come from Chile, we try to give the best therapy upfront because we know we have a lot of attrition in this patient, probably much more than's been reported in clinical trials. So we try to give this therapy upfront. So that's an argument to start with this triplet. But I agree regarding the toxicity. Probably that's something that we've got to start managing beforehand and understand probably what to think or what to expect with each of our patients.
And would the disease characteristics change your mind? Meaning, would you change your opinion for a patient with non-visceral disease? Would you use a triplet combination there as well? Or would you only use it for patients with, high burden disease, like liver mets and so on?
Yeah, probably, yeah. I would make differences regarding the patient characteristics because we still have data, for instance, from ABEMA trials, where they did include patients with endocrine resistance, and we did see benefit just with abemaciclib plus endocrine therapy. So I would consider maybe using the triplet for patients with higher burden disease. Yeah, definitely.
And just before we move into the second line, which is a super crowded space, now that we have a lot of data on second and third line trials that are using abemaciclib, is this impacting your decision on first-line CDK4/6 inhibitors, meaning that you're using more ribo, for instance, so you can use abema later, or this hasn't impacted your practice at all so far?
Yeah, it's a good question. Probably what I do is I prefer ribociclib on the first line, probably because of the overall survival data, even though maybe that's differences that's not directly related to the molecule. We can discuss that later, but yeah, so probably I would start with another CDK4/6 inhibitors and maybe hold back the abema for a second line in a post-progression. Yeah.
So moving to the second line, and that's a super complicated space for me because we've seen data from the Vera trial combining everolimus plus giredestrant, the Ember trial, abema plus imlunestrant, the Victoria trial, again with a triplet of palbo, gedatolisib, and fulvestrant. How are you approaching the second line in hormone receptor positive disease, and what factors are guiding your decisions?
Yeah, it's a good question, and again, probably the second line. What we try to do is try to personalize therapy regarding or according to molecular targets. So we should start testing our patients to determine if we have a PIK3CA mutation or an ESR1 mutation. And probably according to that, we should adjust our therapy. But so far, what we've seen is that many trials couldn't surpass those 6 months of progression-free survival, and probably just this last 3 trials, the EMBER-3, the Evera trial, and the Victoria-1 trial, have been able to give us results that seem or look more promising with PFS of over 9 months or 10 months. So, and these trials, they do not need mandatory sequencing. So it still open the question of whether we do need to start testing all our patients for this decision. And the other thing that's very interesting regarding at least the Evera trial is that the control arm, at least for me, is very important. What they did is they had a doublet therapy. So they use endocrine therapy plus everolimus. That's very interesting because the majority of other trials just use fulvestrant.
Mm-hmm. I do personally think that NGS is key here, and I try to treat my patients according, like what I see in the NGS. I know that, like NGS might not be available everywhere, and that's definitely a thing that we need to address. For SR1 mutated patients, do you think there's still a role for oral SERT as monotherapy for some patients, or you think that we've seen this like really good data with combinations, and then you would always be leaning towards a combination approach?
Yeah, probably there's still space for monotherapy. There's patients that have a long PFS with the first line of CDK4/6 inhibitors and endocrine therapy. So what they're showing is they're really endocrine sensitive tumors, and they have a low tumor burden. And probably we could prioritize maybe monotherapy taking into consideration toxicity and tolerability. So I think there's still space for a monotherapy, but we've got to select our patients.
Exactly. There. And then I do think that, for patients with SRR mutated patients, Evera is a good combination, everolimus plus giredestrant. I think that the main challenge, again, with Evera and probably with Victoria, and it's like toxicity, the safety profile, like oral mucositis, like we need to teach our patients to use these prophylactic measures. And I think, again, maybe, like the decision in the second line will depend on patient preferences, right? On the safety profile discussion. And then also, like how do we envision this sequencing? And there's a lot of new data that will come with new PIK3CA like inhibitors, right? That probably will also change. Yeah. So I think it's a space that it's really moving fast, and it's really, right?
Yeah.
Because we also saw some data today on the alpelisib.
Yeah, exactly. So they show the results of the EPIC B5 that confirmed the benefit of alpelisib after CDK4/6 inhibitors. There had already been a trial, the BELIEVE trial, but it was a phase 2 trial with only one arm, and now they did a formal phase 3 trial. And interestingly, it did show overall survival that wasn't seen before in the SOLAR-1 trial. So probably it as you said, it makes this scenario, the second line, even more crowded.
And I think once we've decided that our patient is no longer a candidate for endocrine therapy, and then we move to this first line chemo, we've seen some disappointing negative data from the ASCENT-07 trial, sacituzumab govitecan versus chemotherapy of choice. First line chemo was negative for PFS, though there's a trend in overall survival. But we have like positive data, right, from the Destiny Breast 06, though there's still a lot of us that feels that capecitabine, for instance, it's a good first-line chemo. What are your thoughts on that?
Well, there's a lot of questions there. So probably the first thing is that with trastuzumab, I think it's a very good drug. It covers probably around 90% of estrogen receptor positive patients because it includes ultra low and low HER2 low disease. So I think TDXD has a really good tolerability and space for treatment in the first line chemotherapy in this scenario. But I agree that still the results of the ASCENT-06 were kind of disappointing because we expected to see positive results with the use of SASI when we give it on first line. But what do I think regarding how to sequence therapy? Probably there's some patient that we could use capecitabine as first line. It's very easy to give. It's oral. Patients, we can space out the controls and the visits, so it's a really good strategy, and maybe focus on patients with a higher burden disease or symptomatic patients to escalate with the use of TDXD. But the question still remains on how are we going to sequence this
I think
ADCs.
I think that was going to be my last question. How do we sequence these ADCs? We have 3 approved ADCs on this space, but we also have a lot of data that they have the same payload, the 3 of them. So using one after the other, we see that there's cross resistance, right? So what are your thoughts on that?
Well, I believe there's no benefit in the sequencing of ADCs with the same payload. I think we have a challenge to look for new treatment therapies with different payloads. But so far, with what we have available, I would prefer using maybe TDXD or one ADC and then chemotherapy, maybe capecitabine, eribulin. But yeah, I'm not a big fan of sequencing ADCs with the data we have so far.
And your wish list for 2026 for metastatic hormone receptor positive disease?
Well, probably what I would like to see is new ADCs with new payloads, and maybe see trials that do sequence these therapies to really answer this question, if there's better therapies available, better than the chemo that we still have, that obviously still has a lot of space. All the patients end up receiving chemo at one point or another.
Okay, so thank you so much. Thank you so much all for all attention, and I hope you to see you in the next SOLTI Young Perspective.
Thank you very much. Thank you, Elia.